Good afternoon, everyone. We are fortunate tonight to have this webinar, the Emirates Society of Ophthalmology webinar under the name of Retina Care Beyond the Present. This webinar would be under the sponsorship of Allergan, and I would like to thank Allergan for their continuous support for all the scientific activity. Tonight we have three eminent speakers. We'll start by Dr. Pier Giorgio Neri from the Director of Uveitis Service in Cleveland Clinic. And we have Dr. Avinash Gurbaksani, our dear friend, the retina consultant and uveitis specialist at Moorfields Eye Hospital, Dubai. And we are fortunate to have Dr. Laurent Kodikian. Dr. Laurent is the professor of ophthalmology and chair of the University of Lyon, France, to share his experience and the French experience about DME. We'll start the webinar by our dear Dr. Pier Giorgio Neri, who will give us a talk about the beyond the pandemic, how to interpret the management of macular diseases during a worldwide crisis. Dr. Neri.
Society of Ophthalmology, an eminent society here in UAE, and with a very well-known reputation all around the world. This is just my financial disclosure. First of all, if we want to tackle the problem, and the title is very broad in terms of what we can talk about, we can see that if we want to summarize, what we do for our patients, we can see that we rely on clinical trials, medical literature, real life, which is our experience, and meta-analysis, which is just a summary of what we can know about it, and then we provide the treatment. Let's say that this concept became very important when, after roughly 100 years, pandemic hit very hard the whole world, and every one of us was very severely affected by what happened over this time. So pandemic has, happened because, as you know, coronavirus widely spread all over around the world, starting from last December 2019, and is still affecting severely the whole world. There was the first wave that we tried to deal with by changing our activity, but now most of the countries all around the world is experiencing also the second wave. So the problem is that the way in getting in contact with this virus can be very variable, and this can happen, in all the services, and that's why we need to wear masks and we need to be very careful about it. So let's say that, this is just a flowchart, as you may see here, that has been proposed by Safari and collaborators, published in British Journal of Ophthalmology this year, where you may see how complex might be the setup for a practice here in the field of ophthalmology. But you can presume that every single discipline has been strongly affected by that. So this is just to tell how difficult it is to deal with a disease and with a pandemic. So everything is very difficult and everything has changed, starting from the way we let the patients to come into our facilities. As you may see here, this is another publication. This is the same publication by Safari, showing how they empirically, create the space and the gap in between two patients, and how we have to use the screens and all other protections for ourselves in order to protect ourselves and avoid the widespreading of the disease. Of course, if we want to summarize for a retina specialist, since here we are, talking about it, we need to see which kind of diseases we have to deal with. So let's say that we can have a huge variety of different diseases, but the ones who are probably, creating an overload of work for those who are the medical providers are age-related macular degeneration, diabetic macular edema / proliferative diabetic retinopathy, retinal vein occlusions, uveitis, and other neovascularization. So mainly the medical retina specialists, they have to deal with these diseases. Talking about what happened during the pandemic, this is another interesting publication by Al Khashab and collaborators that has been published in Clinical Ophthalmology this year. You may see that in some facilities in the United States, and this is just an example, Weill Cornell College and OCB and more, you may see and this has created a scenario that was duplicated and triplicated and, just found in many other places all around the world. Every single clinic had this kind of issue. But to think about it, we can picture in our mind also, how the percentage of intravitreal injections decline over time. And here is a table that is impossible to be commented on because, it's too complicated just to go one by one. But if you go through every single column and you see also, the weeks, you may see how the injections and the number of encounters were reduced and tried, and most of the people was maybe, not treated ideally, and the patients were not assessed ideally because we couldn't do over, the first wave of the pandemic. But of course, every single thing, doesn't happen, by chance, even though you may have like the Newton's apple that can, just fall down, and by observing this, you may understand that you should do something different. So let's say that there were some concepts. So when you are in trouble, you need to picture in your mind on how to fix the problem. And probably the best way is just to understand, the general concepts. Number one, you need to have less encounters. Number two, you have to reduce the time in the facility. Number three, also we need to reduce the number of tests, or maybe try to pick up the ones that might offer, a quick assessment and let us to understand on how to deal with the disease. Plus, we can minimize the number of procedures ideally, and maybe, choose and select drugs that can offer this kind of possibility. So this can create a safe environment. Going through, in detail, you may see that you can have different, diseases. Number one, you can have age-related macular degeneration, retinal vein occlusion, other neovascularizations, proliferative diabetic retinopathy, as I said, diabetic macular edema, and uveitis. So depending on the type of the disease, you may see that for age-related macular degeneration, you have ranibizumab, aflibercept, and these are and then you have also Beovu. Ideally, I should have had an animation for this slide, but unfortunately, the technicians were incapable to do the animation for us. So Beovu is the third and the last drug that we may use. Plus, when we go through the other possibilities, when we have retinal vein occlusion, we have ranibizumab, aflibercept, and then the DEX implant. When we talk about the proliferative diabetic retinopathy, we have just ranibizumab, aflibercept, and we do not have the indication for Beovu still, but for diabetic macular edema, we have ranibizumab, aflibercept, DEX implant, and we have also fluo implant. So let's say that in this scenario, the only one that is giving us, the option to go directly to steroids, which are the last ones that I mentioned, are just the DEX implant and fluo implant. So by considering, what can happen in age-related macular degeneration, we have just a selection criteria for what we may do. We need to choose a drug that is very effective, drug that can offer less numbers of injections, and then the safest. But these are just anti-VEGFs. Let's say that when we talk about diabetic macular edema, we need to think about it, and we need to have new ideas on how to do it on the basis of the peculiarities of the disease. Because when you look at it, you may see that diabetic macular edema and diabetes in general, it is not a simply cystic neovascular disease or an edematous disease, but it is a parainflammatory disease. And when you have something like this, you need to think about all the different processes, starting from the leukostasis and arriving to the production of a series of mediators of inflammation that are the one responsible for the diabetic macular edema. When we go more in detail, we may see that the vascular disease provoked by non-enzymatic glycosylation of all the cells, including the erythrocytes, which cannot squeeze into the vessels and the capillaries, which have a section which is much smaller than the diameter of the erythrocyte itself. And this can create a huge issue because you have the adhesion molecules which are produced, and this is a sort of biologic glue that block and creates sludges of erythrocytes, and you cannot have the normal bloodstream into them. When you consider also, the different theories which are, besides, and basic science has offered a lot, you may see that the overproduction of this kind of soluble mediators of inflammation, including IL-6 and ICAM-1, IL-1, and you can have also for chronic inflammation IL-8, MCP-1, but also VEGF. You may have also the impairment of the vessel wall, particularly of the pericytes, and then you can have the extravasation of blood and also of the plasma. That is the one driving outside all the soluble mediators for inflammation. So just to summarize, you can have from one side the VEGF and the other side these soluble mediators for the inflammation, and merging all together all of them, you have the cascade of events driving to the macular edema. So when you think about it, you may think that probably VEGF is just the tip of the iceberg. So the rationale of what you're gonna do is just to think on the pathophysiology of the disease. And when you have just in front of you the frame, you may see that probably the drug that is tackling directly, the problem that I have exposed just a few seconds ago is just a category of steroids. Since VEGF is just the tip of the iceberg, as I said, and then when you treat it, you are not treating the trigger, but you're just treating the final determination of this process. So let's say that if we want to tackle the origin of the problem, probably steroids are the ones who are offering the best thing. When we look at, I went forward without saying the most important thing. So there are the recommendations provided by your Retina telling that when you have to treat the patient with corticosteroids, it is true that you can have all the details that are mentioned in the guidelines. Like the patient should be pseudophakic, the patient should have, all the treatments, by the anti-VEGFs, which were not so effective in bringing a good solution for the problem that you have, even though you will see later on that this is not exactly like that. And of course, patients that, don't want to come very often to the hospital. So these are the criteria based on the literature, but of course there's much more just behind the curtains. And of course, the most important thing is what the drug may do. So let's say that the first drug that has been introduced is the dexamethasone implant. This is a metronomic the drug delivery system. So it's delivering nanograms of drug every day. So you have the control of the amount of drug delivered per day. And this is attacking the soluble mediators directly and providing a good control of the whole disease. So when we consider what is going to happen in the real life, there was a lot of concern about high intraocular pressure and other problems. I don't want to tease the presentation of Professor Khashab, but when you look at this publication over here, I can tell you that you're very impressed because over 2 years, you may see that the mean CDVA improved from 0.62 of 0 to 0.4 logarithm. And the most important thing, this is to me, is that the mean number of injections is 1.6. So when you look at it, you may get the point. So just by summarizing that, you can picture in your mind that when you have to decide, and the publication of Bush, and there was another animation that unfortunately a technician couldn't, figure it out, Here you have the title that should we stay or should we go? In terms of should we stay with anti-VEGFs or should we go, to the implants for the steroidal agents? Well, I would say that we can start thinking about it on the basis of many things and the evidences that will come out after the presentation of my colleagues. And the last thing that I have to say is just happy Halloween to everybody. Thank you for your attention.
And for the sake of the time, we will not have any questions in between the presentations. We'll just go with the flow. We'll finish all the presentations. Then we will have a panel discussion and the questions and the answers at the end of the webinar. So now we will move to the topic of key questions in DME, especially in the pandemic, by Professor Dr. Laurent Codiquian. Professor, if you can share your slides.
I think it's I'm online. So thank you very much for this introduction, and thank you. I would like to thank Allergan for this kind invitation. So we have a few minutes together to speak about tailored treatment in diabetic macular edema, and so we are going to speak not only about anti-VEGF, but also about Ozurdex. And I really want to share with you my great experience with Ozurdex now, and you are going to understand much more in a few seconds. Next slide, I think it's with my arrow. It works. Okay, you have here my financial disclosures. You can see Allergan, but you can see also Novartis, Bayer, and others. And I like to say that there is sort of neutralization between these disclosures. Let's speak a few seconds about COVID-19, even if my honored and estimated colleague just did it before. You know that unfortunately, we had more than 1 million of deaths due to COVID-19. And I would like to share our French experience about this. Like you probably know, I am the former president of the French Society of Ophthalmology, and so I was the president of the French Society during the first wave and during the 2 months of lockdown we had in France. And I emitted with my administration different recommendations, more than 20 press releases, patient information sheets, etc. And you can find, if someone among you speaks French, you can find everything on this our French website called sfoonline.fr. And to say, I think we were very useful for the French ophthalmologists. And you see, in 4 months, we are about 5,000 French ophthalmologists. We had more than 75,000 connections in 4 months. Next slide, yes, this one. We know that COVID-19 pandemic has required a complete reorganization of ophthalmic departments. We had to postpone non-emergency appointments, and sometimes we used remote consulting. And we emitted different recommendations like other societies did, like the UK, Australian or Canadian societies. We tried to reinforce hygiene procedures and protective measures for patients. At the entrance, patients are asked, and they are still asked, for COVID-19 symptoms. There is no accompanying person in the department, except exceptions, of course, like minor patients, elderly patients, or guardianship patients, for example. We tried to apply the no-wait policy and to have a nearly zero waiting time for all patients, especially in injection rooms. All staff and patients wear masks, and ophthalmologists should wear gloves for examining conjunctiva and disinfect hands, of course. We also applied barrier measures, like we spaced the seats, and we are still spacing the seats with at least 1 meter. We avoid face-to-face patients. We deleted journals, newspapers, toys, etc. And for especially for injections, we try to increase and, if possible, double the ranges available for injections. The first recommendation we edited was made the 18th of March, And maybe you do not know, but the lockdown was done the 17th of March, so one day later. Our recommendations was for during this epidemic to convert most of patients to fixed regimen in order to reduce exposure time in the clinic. So no mandatory ophthalmologic examination, slit lamp examination, fundus examination, so were mandatory, and no CT imaging before the injection if the patient doesn't report any new symptom. So like I said to you, we try to fix the interval. And so we use a maximum effective interval without non-recurrence. And we favored bilateral injections on the same day. The lockdown in France was, first of all, decided for 2 weeks only. So we put a priority to CNV due to AMD, myopia, uveitis. But of course, it was not during during a fortnight. At the end, the lockdown was made for 2 months. And so rapidly, after 2 or 3 weeks of lockdown, we decided to recommend also to treat DME patients, post-RVO patients, or inflammatory macular edema. And to treat these patients, long-term durability drugs are very useful. And that's why I switched some of my patients treated only with anti-VEGF for diabetic macular edema. I switched some of these patients to Ozurdex, in fact, in order to reduce the exposure time in clinics and to have this patient not going back in my clinic. So you are going to say to me, okay, but this is the first time you use Ozurdex. You didn't know about the safety, about the risk of hypertension. In fact, I prescribe prophylactically to these patients drops, dual therapy, lowering drops, in fact. And so I say to this patient, come back in 4 months. And I saw back these patients, and I had no issues with this way of doing, in fact. So I can really recommend it to you. What we could keep going forward, no longer shake hands with patients, probably, to wear a mask during winter flu epidemics, to keep the plexiglass protection shields on slit lamps. Probably we have to ask to our own societies to have a recommendation about, is it really useful to measure visual acuity and do dilated fundus exam on each visit? Probably an OCT and a retinal photography could be enough and save everyone's time with visual acuity measurement and dilated fundus only every 6 months, for example. And we have to prioritize virtual congresses like today. Now, let's go really into the subject of today. I will try to have my next slide, this one, about the use of Ozurdex and anti-VEGF in DME management. On this slide, you can see the 22 peer-reviewed articles are published about Ozurdex. You can see a few Retina Journal, Ophthalmology Retina Journal, the Eye, British Journal, etc. And today, I don't want to teach anything, of course. Today, I really want to share my experience. And so I'm very looking forward to having some questions from you in the Q&A session at the end of today's webinar. And I hope you will have many questions. We have 2 families of drugs, anti-VEGF, steroids, and we have 2 circumstances. We can treat in first line, we can treat in second line. That is to say, we can switch. And we know that one size cannot fit all. I published with different of my colleagues, an algorithm, first line treatment algorithm. And so you can see that it's not only a French algorithm, it's an international algorithm. Like in the authors, you can see there is France, but also Italy, Israel, UK, Singapore, Germany, Switzerland, India, Spain. So it's really international now. What is this algorithm, in fact? Maybe it's too small, but I think it's okay for me. I hope it will be okay for you. It's not too small. If you have aphakia, large iridectomy, iris clip implant, history of ocular infections, we all agree to say that we have to use anti-VEGF in first line. If there are inflammatory biomarkers like serous retinal detachment, hyperreflective foci, many hard exudates, chronic diabetic macular edema, we should rather use Ozurdex in first line. If there is history of vitrectomy, probably theoretically Ozurdex in first line. If there is a real anteroposterior traction on OCT, vitrectomy. About glaucoma, if it's an advanced or uncontrolled glaucoma, we all agree to say anti-VEGF. But if it's a glaucoma under monotherapy, we can use both. About the lens, you have the patient in front of you. If it's a pseudophakic clear crystalline lens, we all agree to say anti-VEGF in first line. Otherwise, we can use both. And you have to remember that the mean age of diabetic patient with diabetic macular edema is 65 years old. And I do not know any diabetic patient with 65 years old with a clear crystalline lens. If you plan a cataract surgery, we have to use Ozurdex perioperatively. If there is history of infarction or stroke even more than 6 months, Ozurdex could be used in first line as a measure of precaution. If there is a proliferative diabetic retinopathy or macular edema appearing during PRP for PDR, anti-VEGF. And lastly, but not the least, in the event of poor compliance or if monthly visits are impossible, we have to use Ozurdex in first line. I'm going to explain to you in few minutes why. In second line, we have to switch from one agent to another. And in third line, we can use fluocinolone implant or surgery. Why? This is the indication of first line. What about the second line and so the switch? Why to switch some patients from anti-VEGF to Ozurdex? First of all, we have to define what is a non-responder. If we use the American DCRNet study group definitions, we could say that functional non-responders mean a visual acuity gain less than 5 letters, and anatomical non-responders and OCT thickness reduction less than 20%. With this definition, approximately 1/3 of your DME patients are functional non-responders to anti-VEGF. In literature, it's between 25 to 40%. But if you take the RESTORE study, that is to say the study with the study that is a pivotal study for ranibizumab in Europe, the number is 35%. So you can remember 1/3. For example, in the early study, that is to say a sub-analysis of protocol I at month 3, you can see that it's about 1/3 for functional anatomical non-responders. And in this early study, we have learned also that there is a correlation between the anatomical response and the functional response. In red, you have the patients that are anatomically non-responder, that is to say a reduction of thickness less than 20% at 12 weeks, that is to say after the loading dose of the first 3 injections. And now if you look at the graph, you can see on the vertical axis the visual acuity change, so the functional response. So for the patient in red that are anatomically non-responder, over 3 years, they will remain functional non-responders. How to explain non-responders in diabetic macular edema? Or in other words, who are the main protagonists in DME? Inflammatory mediators or VEGF? One of the key messages of tonight is that VEGF is not increased in the vitreous of all patients with DME. If you look at the mean VEGF level, it will be increased. And that's why you are going to, you can treat and you treat your patient with DME with anti-VEGF sometimes. But the key message I want to deliver tonight to you, and I want you to understand that, is that some of your patients, 1/4 to 1/3 of your DME patients have a normal VEGF level. And look at the patients in the red circles, they have DME, but they have a normal VEGF level. I'm going to show it to you in 2 studies. For example, this one, on the left part, you have diabetic patient. On the right one, control patient, normal patient. Look at the last line, VEGF. If you look only at the median VEGF level, 1,000 with diabetes, 66 with control. And that's why you are going to use anti-VEGF. But now, don't look at the median, look at the range, that is the minimum and the maximum numbers. for control patient, you see normal patient have, it's between, I think it's written 11 to 500. And look for diabetic patient, 26 to 2000. There is an overlap. Some diabetic patients have a normal VEGF level. And again, if you compare without macular edema or with macular edema, you can see with the median level that there are 3 times more VEGF with macular edema in the patient with macular edema. But this is only the median. If you look again at the range, you can see easily that there is again an overlap. So remember that 1/4 to 1/3 of your DME patients have a normal VEGF level. And so logically, they will not answer to an anti-VEGF. And steroids address the multifactorial nature of DME because steroids are efficient against the inflammatory mediators and look, also the VEGF. Whereas the anti-VEGF will be efficient only against the anti-VEGF. The VEGF, probably more like the steroids. Nevertheless, you have a more polyvalent, a more broader action of steroids in comparison to anti-VEGF. Broader spectrum of activities than anti-VEGF. So Ozurdex is a Swiss army knife of the retina specialist. And now if you compare the rate of functional anatomical non-responders in DME with anti-VEGF and with steroids, you can see that there are 2 times less non-responders with steroids. So 1/3 of your patients will be functional anatomical non-responders with anti-VEGF, only 1/6 with steroids. And just like I said to you, the VEGF level, when the patient has normal VEGF level, they will not answer to anti-VEGF. I said to you about 1/4 to 1/3 have normal VEGF level. And now look, this clinical evidence. The rate of non-responders to anti-VEGF does not really vary over time, meaning that it's not dependent of the number of injections. And look, for example, for the RESTORE study, but this is the same for protocol I. The rate of functional non-responders at year 1 was 35%. If you look at the rate of functional non-responders at year 2 for the patients that continued to receive ranibizumab during the second year, that is to say, the majority of the patients, 34%. And the rate of patients that received the ranibizumab during the third year, 34% of non-responders. So obstinacy is not a guarantee of success. On the contrary, delayed treatment is a loss of opportunity because duration of edema matters. And look at the RISE and RISE study. If you treat the sham patient, when the sham patient were treated after 2 years, just here, after 2 years, and they received the effective treatment, ranibizumab, it was too late. They never reached the same level of the patient initially treated with ranibizumab. So if you use an effective treatment, but if you use it too late, when it's too late, it's easy to remember that it's too late. And we know that the longer the duration of DME, the more the visual acuity decreases. Again, in this very recent study published in the Eye Journal 1 year ago, the longer the duration of DME, the more the visual acuity decreases. So you have understood why to switch. Now the good question is when to switch. Don't wait too long to switch, or even treat directly suitable first-line patients. Let's compare two studies. I published the REDEX study in the Retina journal 4 years ago, and the pre-DMX study in the Ophthalmology Retina journal 2 years ago. REDEX study. The duration of DME for the patients included in the REDEX study was 2 years. It's a long time, 2 years. But it's like the pivotal study mid. But in pre-DMX, it was only 2 months. Look at the proportion of naive eyes. 1/4, 3/4. Look at the results now. In REDEX, we had to wait 1 year to obtain significant results, plus 4 letters. At 2 years, plus 5 letters. At 3 years, plus 9 letters. But now look at pre-DMX. In pre-DMX studies, you have understood that the patients have had a better ability to gain vision because duration of DME was very short, 2 months. 3/4 were naive. As soon as the second month, the gain was plus 10 letters. So don't wait too long to switch or even treat directly suitable first-line patients and naive patients. And this is logical because naive patients means better baseline visual acuity, earlier treatment, a better ability to gain vision, and so a predicted better visual acuity gain and a predicted better final visual acuity. If you switch, which family of agents do you choose next? The answer could be found by looking at patients with open-angle glaucoma, I think. It's recommended by the European Glaucoma Society to switch to another class of monotherapy family. If your patient will not answer to a beta blocker, are you going to use another beta blocker, or are you going to switch to prostaglandin? I think this is the same response for anti-VEGF and Ozurdex. When can we predict functional response to anti-VEGF therapy? Remember the early study. In the early study, the patients were divided according to their functional answer after the loading dose of the first 3 injections. And so 40% on protocol I were functionally non-responders after the loading dose. And the mean subset of patients remain non-responders. So the author said concluded that predictability is obtained after the first 3 injections. I don't completely agree because there are tables in the papers, and look at one table. If you look only at the patients that are functional non-responders after the loading dose, so all these patients, 100 of patients, non-responders at 12 weeks. If you inject 3 additional injections, so you are waiting 3 additional months, so you are now at 24 weeks, 6 months. You can see that you reduced the number of non-responders, the rate of non-responders to 100 to 63%. But now, if you continue to treat during 3 years, over 3 years, you will reduce the rate of non-responders to 63 to 53%. So you will win for 10%. But what do you want? Do you want to win for 10%? Or do you want to lose for 53%? I think you have the answer. That's why I wrote in the yellow box that functional predictability with anti-VEGF seems to exist after the first 3 to 6 injections. Therefore, we have to wait 5 to 6 months after treatment initiation before switching. But please, don't wait anymore 9, 12, 15, 18 anti-VEGF injections before switching. And what I said to you is shared by the community, because look at this survey presented at the American Academy 3 years ago. More than half of DME patients are switched towards steroids before the 6th injection. And this is shared by the American people as the non-American people. And you know that American people, American physicians don't really like steroids like we like the European guys, like we like and we like the use of steroids. And even in US, they agreed. And the same poll was presented last year at the American Academy, and you can see the same tendency with a higher number of physicians switching before the 6th injection. We have 2 types of studies in medicine: the interventional randomized controlled trials and the observational real-life studies. And we need to have also data with these observational real-life studies, because there is no selection of patients in these studies. But the level of evidence is lower with these studies. So it's important not to have 1 or 2 studies, but to analyze many studies. And I'm convinced that if all the studies, these observational studies, the real-life studies, made by different teams in the world, go in one way, this way is a good way, because it's impossible to be wrong for all the different teams in the world in the same time. That's why I decided to analyze and to publish a study, an analysis of all the observational studies published on PubMed until the 1st February of 2018, with the 3 anti-VEGF and Ozurdex, with at least 10 patients included and at least 6 months of follow-up. And I found not 1 or 2 studies. I found 63 studies. 32 papers with anti-VEGF, 31 with Ozurdex. It corresponds to more than 8,500 eyes. The mean follow-up for the anti-VEGF studies was 15 months, whereas it was 10 months for the Ozurdex studies. Look at the mean number of injections. It was not 8 to 9 like in interventional studies. It was only 5.8. And the mean gain was only almost plus 5 letters. So reduced outcomes versus clinical trials. whereas the mean number of injections with Ozurdex was 1.6, with a mean visual acuity gain of plus 9.6 letters. Look at the results differently. On the horizontal axis, you have the baseline visual acuity. On the vertical axis, the visual acuity gain. Each point, each circle corresponds to one article. I don't have to speak. I think these graphs speak by themselves, because you can see easily that real-life outcomes with Ozurdex seem to be better than real-life outcomes with anti-VEGF. Look at the result differently. Each column corresponds to one article. In blue, you have the baseline visual acuity. In red, the visual acuity gain. So the addition, the sum up corresponds to the final visual acuity. You can see that the mean final visual acuity was similar between both families, but with a worse baseline visual acuity for Ozurdex and a better visual acuity gain for Ozurdex. And you could say, okay, it's easy. I have the explanation. It's due to the worse baseline visual acuity. No, it's not so simple, because now you can see that I divided the visual acuity gain according to the different level of baseline visual acuity. And if you look only at the better baseline visual acuity subset, more than 60 letters, for anti-VEGF, the mean baseline visual acuity was 65 letters, with a mean gain of plus 3 letters. But the mean baseline visual acuity for the Ozurdex was 68 letters, and the mean gain, nevertheless, was 8.8 letters. So the better observational outcomes with Ozurdex in comparison to anti-VEGF don't seem to be linked only to the baseline visual acuity level. Of course, baseline visual acuity level is a biomarker, but I mean that there are other predictive factors that could explain better outcomes with Ozurdex in comparison to anti-VEGF. And these two following graphs are very important to understand. You have on the horizontal axis the mean number of anti-VEGF injections. On the vertical axis, the visual acuity change. In blue, interventional studies. In red, observational studies. With anti-VEGF, there is a linear relation. One injection means one letter gain. If you succeed to inject 8 to 9 times the first year, you will obtain 8 to 9 letters gain. But if you inject only 4 to 5 times, you will obtain only 4 to 5 letters gain. And this is what you obtain in real life. In real life, the mean number of anti-VEGF injections and letter gain are below 6. And this is a major issue, mainly due to non-compliance with a tight schedule of monitoring and injections that is mandatory to achieve best outcomes with anti-VEGF. But now look with Ozurdex. The real-life outcomes with Ozurdex are superior to those of clinical trials, and in real life, gain with Ozurdex is not below 6, it's greater than 6 letters. So if you are parents, you are aware of that notion that sometimes theory is different from reality. So it's difficult sometimes to reproduce interventional results in observational studies, but we succeed more easily with steroids. Just finish in a few minutes about safety. It's very important to remember that Ozurdex is not the evil. About hypertension, 3 important key messages. The first one is that you only have 11% of IOP more than 25 mm for DME. And this is statistically less important than for RVO and uveitis. The second key message is that I published a Safodex study 4 years ago in the Retina journal. And in my cohort of my first 1,000 Ozurdex injection, I published Safodex study, I found 120 hypertonic cases. And it's very important to remember that topical treatment alone was sufficient in 97%. The third key message is that hypertension with Ozurdex was, in my big cohort, was transient and did not result in sustained hypertension or steroid-induced glaucoma, contrarily to triamcinolone, for example. And we publish it also. And don't forget, my friends, that hypertension is also described with anti-VEGF. Sustained hypertension has been reported since 2010, following multiple anti-VEGF injections. And we know, thanks to the DCNet American group, that after the first year of anti-VEGF therapy, 5 to 10% of patients experience chronic hypertension. That is to say, a relative risk of 3. Does cataract surgery under Ozurdex worsen DME? The answer is no. There is no worsening of the DME after surgery when it's framed with an injection 2 to 4 weeks before or the day of surgery. And so, there is no delay in visual recovery. This slide is very important. Please remember that the burden of DME and its costs are lower with steroids than with anti-VEGF, because in interventional head-to-head studies, Major, Bevodex, but also in observational studies, the analysis I published about 63 papers. Always, I found that there are 3 times fewer injections with steroids compared to anti-VEGF. So probably a better observance in such diabetic patients. And so Ozurdex has a favorable cost-effectiveness ratio for society and payers. In interventional studies, head-to-head studies, there is non-inferiority in comparison to anti-VEGF. With studies, there are better outcomes with Ozurdex in comparison to anti-VEGF. Ozurdex is effective as a rapid set of action, and the duration of efficacy is up to 6 months. About side effects, they are generally predictable, transient, manageable, with less injections, so less burden, and a favorable cost-effectiveness ratio for the society and the payers. I would like to thank all my collaborators for present studies and to thank you very much for your kind attention.
Overview of all the studies and efficacy of Ozurdex and steroids as first and second line treatment for DME. Now I will introduce my dear friend Dr. Avinash Gurbaksani. He will be presenting about DME biomarkers, which ones and why. So Dr. Avi, if we can go.
Good evening. Thank you very much for this opportunity to present about biomarkers in diabetic macular edema. So this is the disclaimer. So these are Allergan. These are not Allergan slides, and these are my personal slides. So what are the mechanisms of DME? So we've discussed some of that both in Pierre Giorgio's talk and Professor Laurent's talk as well. And we've seen that there are local and systemic inflammatory markers that are upregulated in diabetes. So in systemic conditions during insulin resistance state, the body produces all these inflammatory markers, and in the eye you get the local inflammatory markers, which we are all familiar with, including VEGF, but also TNF alpha, interleukin 10, interleukin 6, etc. So and we've seen from the 2 other talks that there really is an inflammatory environment in the eye because of diabetic macular edema, and that's part of what drives macular edema. And how do we see this? So we're looking for biomarkers. So what is a biomarker? So biomarker is basically, by definition, short for biological marker, and it is something that measures the biological state. So by definition, it's a characteristic that is objectively measured and evaluated as an indicator of the normal biological processes, pathogenic mechanisms, or pharmaceutical responses to an intervention. So how do we measure them? What do we measure? And why do we measure them? So we look for, objective. What are the real objective measures that we use to guide us in DME management? I mean, really, we're basically looking at visual acuity as one of the main drivers, and central retinal thickness. But there are so many other factors that we looked at. So when we're looking at the we look at quantitative, objective measures. I said we only had two, but the rest of them, we look at, these are the subjective or qualitative measures, which are subjective at present. So all these OCT features that we discuss, hyperreflective foci, drill, cysts, fluid, macular traction, all these things today are still subjective. But of course, there will be a value attached to these at some point. And ischemia, vascular density. So all these things, at the moment we look at a scan and we say, okay, yeah, what is this? Yes, there's some VMT. There are some cysts and some. So some is not a quantitative measure. It's a qualitative or a subjective feature, which, with time will become quantitative. So these biological markers that have been identified are now looking to be measured. So visual acuity, this was a paper from John Marshall's group about 10 years ago, and he produced this beautiful electron microscope pictographs of macular edema. So you can see here, these are the Mueller cell processes, which have been elongated. And, this is why we call it cystoid, because there aren't really cysts. They look like cysts. The idea is that fluid that has leaked in stretches these Mueller processes, and then that causes the macular edema. And then that is measured on the OCT. So they looked at all these different levels and tried to get a relationship between the OCT parameters or the and find what correlates with, or what zone of the OCT correlates with vision, and they found significant correlation at the 0.05 level for all these zones. So OCT and vision can be correlated together. They don't have a great correlation, but that paper showed that it did. What are the other biomarkers? Now, we've looked at the other two presentations, and really these are the main biomarkers that are used. So this paper beautifully showed us all these different biomarkers: subretinal fluid here, intraretinal cysts. Here you have the ellipsoid zone, integrity. You also have hyperreflective foci in these D, E, and F. And these are graded also as to the number of hyperreflective foci. The cysts have also been measured. So which one of these really does stand out? And what is the one that we would like to use? So when they looked at these, they looked at the forest plot, and they found that for every they looked at patients receiving dexamethasone implant, and they looked at best corrected visual outcome at 2 and 4 months. And basically, these biomarkers really did stand out. So the predictors of a greater than 10-letter gain in best corrected visual acuity in these patients, eyes presenting with subretinal fluid were more likely to gain more than 10 letters of vision. So subretinal fluid really became quite an important indicator here. So this is a very significant biomarker which we use in our day-to-day practice. When we look at the OCT, we don't really quantify it at this point, but subjectively we know that this patient has got subretinal fluid, and we use that as a strong indicator to guide our treatment. And the patients who had higher amount of subretinal fluid responded better to the dexamethasone implant. The inner segment, outer segment continuity. So for every increase in the continuity value, a patient was less likely to gain a best corrected vision. So at 2 months. What about the location of the hyperreflective? So for every increase in the hyperreflective location value, which is either the internal limiting membrane or outer plexiform layer, a patient was likely to gain vision. So this was also the location of the hyperreflective foci was very important. What about vitreoretinal interface, and for every increase in vitreoretinal interface value, like VMT, a patient was more likely to gain vision. So these became very interesting factors in this study. So we've seen the ellipsoid zone. They divided into different groups, Group A, Group B, and where they could identify is there a present ISOS ELM or is it absent. And the patients where they had the disruption or loss of ISOS, they didn't do as well as the ones who had an intact ISOS. So these are another biomarker that we can use to predict the function or the outcome of our treatment. Drill is also something that we've used in the recent few years. And drill, which is disorganization of retinal inner layers, is a predictor of visual acuity in patients with center-involving macular edema. And so when you have a discontinuity or when you find that these layers are disorganized, you cannot make out the inner retinal layers, you know that these patients are less likely to do well. Also, you may have somebody who's been treated but hasn't had a great vision improvement, and when you look back, you may see that actually they had a drill positive, and this may be the reason that they haven't done well. So when we look at the OCT, we look at all these factors. Look at this patient has got before and after treatment. This patient's got diffuse macular edema. That's important. They've got hyperreflective foci. They've got the subretinal fluid here. They've got a central macular thickness of 578. And then, this patient has been treated. The central macular thickness has come down. The cysts are just a few residual cysts, and there is a reorganization in the outer retinal layers. So you can see here that the outer retinal layers are disorganized here, and they are reorganized. And this patient has done well with the treatment. So hyperreflective spots became very important. You can see that compared to the control, patients with no diabetic retinopathy or even with non-proliferative retinopathy, they did have hyperreflective foci. So we can say that compared to control, diabetic patients, even without retinopathy, did have some hyperreflective foci. So this may work as a predictor that these patients do have an inflammatory element that is brewing, and they may end up having macular edema in the future. So this is, remember, patients with no diabetic retinopathy, and they had hyperreflective foci. Almost half the patients had before they developed diabetic retinopathy. So hyperreflective foci or spots, they become quite an important factor in this. We also have, so that sort of similarly shows what I was talking about. What about OCTA? Here we have the subjective factors in the OCTA. We can use it to identify microaneurysm, vascular loops, areas of non-perfusion, etc. And then these can be quantified here. And then there have been several studies to look at these biomarkers in OCTA. And you can see that the FAS area, the vascular density have become two very important factors. So you can look, I'll just skip through one of these and really get to the meaty part in this. So you can see here that in the control group, the FAS area is well preserved, and in the superficial and the deep vascular network, and the vessel density is quite good. But when you look at the diabetic patients, look at the mild, moderate, and proliferative diabetic retinopathy, really you find that there is the vascular density or the vessel density has reduced, and that happens in a linear fashion. So vessel density is a very nice way of predicting these patients are going to have retinopathy and maculopathy. So another biomarker that has been identified through OCTA. And these bar graphs illustrate the same. So what about ischemia? So looking at this picture from the AJO study that published, now this was several years ago, they used ultra-wide field angiograms and they identified areas of ischemia in the peripheral retina. So this is not even in the central retina. They found patients who were not responding to treatment. And then these patients, they had wide field angiogram and they realized that there was a lot of ischemia in the peripheral retina. And then these patients were unable, and this was perhaps the reason that they were not responding to treatment. So they tried to quantify this and came up with something called the ischemic index. And I know that wide field OCTA has also been used to try and come up with an objective value for this. So another important biomarker, the amount of ischemia, not just in the center, but in the periphery as well. And so this sort of, marries all these things. There's color photographs showing microaneurysms, which are then seen on fluorescein. Some of these extra ones are identified on the OCTA. And here's the patient before treatment. They have subretinal fluid, hyperreflective foci, outer retinal disorganization. And after treatment, you can see that a lot of this has improved. But don't worry, we don't have to do all the work ourselves. You see, in the future, AI is going to do this. And you can see this paper that showed beautifully how AI compares with graders. And really, there was 100% correlation that the AI was able to pick up fluid, different types of fluid. And not only that, it could quantify the amount of fluid. So, you can rely on your AI, which will analyze these images and just give you a value. And then that value can be used sort of both pre and post treatment. Yeah, AI can also be used. Here again, you can see this beautifully. It picks up the areas of fluid, intraretinal, subretinal, and so even areas that you and I would miss. Also, very good at detecting areas of microaneurysms, exudates from the color images. So really great tool here that is going to be in our hands very soon. So several biomarkers aid us in our decision-making in diabetic macular edema. Subjective markers such as quantifying fluid and the level of ischemia will soon become objective. Macular thickness does not always correlate with visual acuity because so many other factors are involved in predicting the visual acuity. So there's no absolute guidance of which biomarker drug correlation, although some evidence does exist. And we've seen through this evening that because of this large inflammatory arena that exists in these diabetic eyes, perhaps steroids has a more wider role in these treatments. And decision-making or quantifying this will all be taken out of our hands soon, thanks to AI. So thank you very much. And we're around for questions later.
Now we'll move on to the last presentation by Dr. Kolikian for the consensus plan for DME. And after this, we'll have the panel discussion and the questions.
So thank you for letting me having the opportunity to present to you the French result of our Delphi. If you agree, I will present to you what is a Delphi, and after our French results, and you will see that they are completely in my first lecture, and then I will finish with 3 case reports. So disclaimers again. Okay, financial disclosures. It did not change from a few minutes ago. So now the Delphi method. The Delphi method is a structured communication technique originally developed as a systematic, interactive forecasting method, which relies on a panel of experts. Delphi is based on the principle that forecasts or decisions from a structured group of individuals are more accurate than those from unstructured groups. The experts answer questionnaires in 2, rarely more, maybe sometimes 3, but classically in 2 rounds. After each round, the steering committee provides an anonymized summary of the experts' forecasts from the previous round, as well as the reasons they provided for the judgments. And these reasons are very important to analyze, because you can change for the second round the way you ask the questions. Thus, experts are encouraged to revise their earlier answers in light of the replies of other members of their panel. It's believed that during this process, the range of the answers will decrease and the group will converge towards the correct answer. Finally, the process is stopped after a predefined stop criterion, like, for example, 2 rounds not more, or 3 rounds not more, for example, or achievement of consensus. And the median scores and distribution of ratings of the final rounds determine the results. So you have 2 different groups in Delphi method, a steering committee, a rating group. In the steering committee, you will find 4 to 6 KOLs, representative of daily practice and able of defining the relevance of the published studies and the different clinical situations evaluated. The rating group is made by professionals working on a daily basis with those affected by the recommendation. Of course, there is absolutely a necessity of independence between the steering committee, which formulates the proposals to be put to the vote, and the rating group, which judges the appropriateness of not of the proposals submitted. So you have, you can see here the frame of the Delphi with different steps. So you can see the steps including involving the steering committees on the up part of the slide, literature review, scientific arguments, writing questions, and so analysis of the first round and the second round, of course. And on the bottom part, of course, the 2 quotation rounds with predefined rating rules. And at the end, we have to write the article. About the rating rules, they are predefined and transmitted to the rating group before the first rating round. The rating group has a questionnaire, and next to each item of the questionnaire is placed a discrete numerical scale graduated from 1 to 4, or sometimes 1 to 5, you are going to see it, or in our French Delphi, and it's more classical, 1 to 9. 1 is totally inappropriate, 9 is totally suitable, and after you have this hesitation between. The appropriateness or inappropriateness of the proposal is defined by the value of the median and the distribution of all the answers obtained on a scale of 1 to 9, for example. There are few main methods used in literature to achieve a consensus. I do not have the time to go into details, and I'm going to share. It's better to share with you what did the other teams. So you can see here the rules of interpretation of European Delphi about DME and Osidex. In Italy, the voting results were scored as very much agree, neither agree nor disagree, or very much disagree. So the rating rules was with 5 different possibilities. And consensus was considered when 3/4 of respondents or more voted very much agree or agree with a particular statement. In Germany, voting results were scored with only 4 possibilities: very much agree, disagree, very much disagree, and consensus was reached if at least 3/4 of participants agreed or disagreed with the statement. And for the Spanish one, descriptive analysis of the results was performed for the Likert type questionnaires items with, like the French one, the 9 positions quell, 1 to 3 disagreement, 4 to 6 it's neutral, 7 to 9 agreement, like the French one. And the criteria was more permissive than our, because when less than a third of panelists ranked a statement outside the median value, an item was considered to have reached consensus. So 2/3 are enough to obtain consensus. The French one is more strict, more rigorous, probably. We used like the oncologist made, and so the LASCO rules, in fact. And so we predetermined that a strong consensual agreement would be reached for a statement when more than 3/4 of scores were more than 7, 8, or 9, and the mean score was 8 or 9. And when only one of these 2 parameters were met, it would be considered as a good consensual agreement. And I'm going now to show to you the results. So the study aimed to complete the 2-round voting process with 25 to 30 experts from across the French territory. We decided to invite 87 ophthalmologists. 2 experts refused, 46 never answered. And so overall, the final number of experts included in the study was very high, 39. So it was very nice. From across France, there was no dropout between round 1 and round 2. This is very important to emphasize. Look at the results now, very important. So we had strong consensus for these 3 assertions. Inflammation is a key component in DME development. Pro-inflammatory factors like cytokines are found in DME eyes before clinical symptoms. Inflammation is present both during acute and chronic stages of DME. Ozurdex demonstrates not only anti-angiogenic, but also anti-inflammatory and blood retinal barrier stabilizing properties. We had no consensus about these 2 assertions. In DME, OCT allows to identify inflammatory markers. Some inflammatory markers revealed by OCT are useful in treatment choice. About first-line indication, we had strong consensus or good consensus for all these assertions. Ozurdex provides good anatomical response and fast onset of action in large proportion of naive patients. Anti-VEGF should be avoided in naive patients who have had a cardiovascular event in the past 3 months. Ozurdex is the first-line option to consider in vitrectomized patients. Ozurdex is the most appropriate treatment option for very active patients, lack of time for injections, follow-up, compliance concern. Ozurdex is the first-line option to consider in patients with serous retinal detachment. Ozurdex is the first-line option to consider in patients with hyperrefractive dots. Ozurdex is the first-line option to consider in patients with numerous hard exudates in OCT. Ozurdex is the most appropriate treatment option for patients without proliferating diabetic retinopathy and candidates for cataract surgery. Ozurdex can be used as first-line therapy for DME pseudophakic patients. In combination with PRP, Ozurdex can be an option in DME patients with proliferating diabetic retinopathy when anti-VEGF therapy is not possible. We had strong consensus for 3 assertions. After 1 injection of Ozurdex, there is no need to wait for a 5 letters reduction in visual acuity for a significant or a significant antiviral recurrence before retreating. After several injections of Ozurdex, retreatment should be considered as soon as hard exudates recurrence without waiting for visual acuity reduction. Most of the time, interval between 2 Ozurdex injections is between 3 and 5 months the first year of treatment. And we had no consensus about after several injections of Ozurdex, retreatment can be considered on a dry retina when the patient rhythm of recurrence is known. The physicians are not yet ready, like they are already ready with anti-VEGF. And no consensus about most of the time, the minimal interval between 2 Ozurdex injection is regular during the course of treatment. And probably they are right because it's not regular. It increases with time. I'm going to show it to you in a few case reports. We had got good consensus or strong consensus with these 3 assertions. The patient should be considered non-responder to anti-VEGF when there is no or incomplete efficacy after 3 to 6 months of well-conducted treatment. A patient with recent DME should be considered non-responder to Ozurdex when there is no marker of efficacy after 2 injections. And functional lack of response is usually defined by the visual acuity improvement less than 5 letters. Strong consensus, anatomical lack of response is usually defined by a reduction of central blood retinal barrier thickness, OCT thickness less than 20%, and or the lack of significant intraretinal cyst alteration. And we had no consensus about the number of 1-year functional non-responders, the comparison, between the number of non-responders, the comparison between anti-VEGF and Ozurdex, and also non-consensus, strangely, with this assertion, in real life, the first year 8 to 9 anti-VEGF injection regimen is rarely achieved. I'm very surprised when, especially when I showed to you the results of the analysis of the 63 papers I did. About safety, we had very strong consensus for almost everything. For the vast majority of patients, local pressure lowering treatment is enough to control the IOP elevation induced by Ozurdex. IOP follow-up is mandatory between 1 to 2 months after each of the first 2 Ozurdex injections. And, very important, without any IOP elevation after the 2 first Ozurdex injections, IOP follow-up can be reduced, not mandatory after every injection, but must stay regular. Compared to uveitis or RVO, the risk of Ozurdex-induced IOP elevation is less important in DME. Compared to triamcinolone, the risk of Ozurdex-induced glaucoma is inferior. Strong consensus also for, in order to improve postoperative visual acuity and prevent postoperative edema worsening, DME patients candidates for cataract surgery should be administered with Ozurdex a few weeks before or the day of surgery. And due to the high rate of false negatives, a topical steroid loading test is not necessary before the injection of Ozurdex. And good consensus for the last one, in case of effective filtering surgery, there is no contraindication to Ozurdex use. So to synthesis, we had 38 statements, assertions, and we obtained consensus for more than 3/4 of these assertions. Now the last part is about these 3 case reports in the 15 minutes remaining. So the first one is a switch from anti-VEGF to Ozurdex, 70-year-old woman, type 2 diabetes, hard exudates on fundus, and she was pseudophakic with only 35 letters at baseline. So you can see at baseline the right eye on the left part and the left eye on the right part, of course, of the slides. You can see the 1 month after the first ranibizumab on the right eye, because there was no treatment for the left eye. 1 month after the third picture is 1 month after the second ranibizumab, 1 month after the third ranibizumab, and 1 month after the first ranibizumab on the left eye. You can see that the visual acuity was quite good, but there was no real efficacy about sickness. You can, on the last part of the slide, 1 month after ranibizumab number 4 for right eye, 1 month after ranibizumab number 2 for left eye. So you can see, I'm sorry, go back. You see the decrease, 64 letters, 35 letters, the decrease in visual acuity. You can see an increase of sickness despite the fact that we inject monthly. So there was no anatomical and functional efficacy of anti-VEGF. So we decided to switch to Ozurdex. And so you have here baseline before Ozurdex injection, and look the results 1 month after Ozurdex, 3 months after Ozurdex. We injected both eyes. 5 months after Ozurdex number 1. And here you are 6 months after Ozurdex, and you can see a recurrence. I'm sorry, there was a recurrence at month 5. I'm sorry. I go back. Here you can see the recurrence at month 5. So we decided to re-inject both eyes. You can see here results 6 months after Ozurdex number 2. And you can see a recurrence for the left eye. So we did the Ozurdex number 3 for the left one. Later you can see month 14 after Ozurdex number 2 for the right eye. Month 8 after Ozurdex number 3 for the left one. We decided to re-inject the left one. And here you can see the recurrence for the right eye 19 months after Ozurdex number 2. And you can see hard exudates on the left eye, but we did not decide to inject because the visual acuity was stable, sickness also. And we only decided to inject the right eye for Ozurdex number 3. And you can see here results, month 8 after Ozurdex number 3 for the right eye, month 13 after Ozurdex number 4 for the left one, and we decided to inject Ozurdex number 5 for the left one. And here you have month 17 for the right eye, no recurrence, very good vision, 71 letters. And for the left one, 49 letters. There was a recurrence, but he refused injection because visual acuity was good. And you can see here month 22 after Ozurdex number 3, no recurrence, right eye. Month 14 after Ozurdex number 5, and so we decided and he accepted to have Ozurdex number 6. So you can see on this case report, few recurrences with time, increase in interval retreatment, like I said to you before, and Ozurdex is known to be more efficient if there are hard exudates. The second case report is a switch from aflibercept to Ozurdex. Visual acuity was 60 letters at baseline, and we decided to inject aflibercept Elea. So we respected the label with first 5 injections. And you can see we had anatomical response, but no functional response. We decided to re-inject 6 injections of aflibercept. No answer, so a 7th. We decided to try to respect the label, so we did not re-inject 1 month later, but 2 months later with a number 8 and a number 9 with no visual acuity improvement, 60 letters, and only 19% of decrease in sickness. So we stopped Elea and we switched to Ozurdex. And this is real life. To be honest now, like I said to you, I would switch before the 9th injection. It's too late to switch after 9 injection. But this is, again, I'm not lying, this is real life. And look at the results. At month 2 after Ozurdex, for the first time, we had visual acuity improvement. 69 letters plus 9 letters with a 37% decrease in sickness. So good functional anatomical responses. And so, of course, we will have fewer injections. And the last case report I wanted to share with you tonight is Ozurdex as first line. It was a man with a irregular medical follow-up, never treated before for DME, with a myocardial infarction 2 months ago. He was pseudophakic with a very bad OCT, probably with drill. We do not really know. There is still an ellipsoid layer. Nevertheless, we were worried about this OCT aspect. And so there were very good indications for Ozurdex as first line, irregular medical follow-up, myocardial infarction history, very recent acute history. He was a pseudophakic patient. And so look at the results. Month 1, very nice. We went for 39 letters. We went until 53 letters. I was very surprised. And we had a recurrence at month 3.5. So we decided to inject a second Ozurdex. And look, the OCT at month 3. And we had the recurrence at month 5 this time. We did a third Ozurdex injection. And the recurrence was obtained at month 6 this time. Ozurdex number 4. And you can see here, month number 6, there was no really very, very small recurrence. And the real recurrence this time was obtained at month 8. So what do we learn about this case? We have the impression of an increased intervals between recurrences with 8 months, between the last 2 doses of Ozurdex. So real-life study called REDEX. We had only 5 injections in 2 years. This Ozurdex is ideal for patients for whom regular follow-up is difficult. So there is no vital risk, no loss of efficacy over time, and no hypertension in this case after 5 injections. And you see, we were right to use Ozurdex because the patient has still not returned in consultation despite the notification to attend. So with these diabetic patients, sometimes compliance is a real issue. Thank you for your attention.
Sir Karikian. So we should open now the panel discussion. And we have Dr. Neri, Dr. Avinash, and Dr. Karikian. We have multiple questions to answer, and actually all of your presentations added up to the understanding of the DME to start with and the original problem. So I have a question. Do you think that the inflammation is the starting point of in the cascade of DME? This question to Dr. Neri.
The answer, of course. There's plenty of publications proving that. This is undisputed. There's a lot of studies coming from multiple schools. Well, there's a school of Paris. There's a group of Aberdeen that has proven this many years ago. It has been proven many times, and for certain VEGF is not the final, is just the final target, or maybe we can hope to have just negative feedback. But if you want to target the disease, there's no question about the possible the nature of the disease as a para-inflammatory disease. And I remember that when I was even a resident 20 years ago, there was a very nice article, is diabetes an inflammatory eye disease? And I think that, that paper, was one of the very first who speculated about the nature of diabetes as an inflammatory disease. So yes, it is.
Okay. I agree with you.
If I can just add,
definitely.
As I showed, the hyperreflective foci were present in diabetic patients with no retinopathy in more than half of the patients. So that proves, doesn't prove, but it indicates that there is some sort of inflammatory process that has that is a precursor to what we see clinically.
Yeah, well, if I can furthermore address, I mean, this is just a Padua stuff. Padua is the school where there's Professor Midena that has created a huge number of publications about it. Even though I would say that as immune biologist, this is just a mere speculation about the possibility to have hyperreflective foci like activated microglial cells. But anyway, there's plenty of other publications with flat-mounted animal models, and even the vitrectomy in patients with proliferative diabetic retinopathy. If you consider that interleukin-6, intravitreal interleukin-6 in vitrectomized eyes with proliferative diabetic retinopathies is 4 times higher than VEGF, you can get how important is the markers for inflammatory for diabetes as an inflammatory eye disease. So yeah, I think, Avi, that you made the point. I don't know what these foci are, but foci this are indicating a certain biomarker for inflammation.
So let me just interrupt you here. By having this as a fact, we should all understand that a part of our treatment armamentarium for diabetic macular edema should be steroids. It can be either a second line of treatment or a first line or a combination treatment. And we messed up this during our talk. Sometimes we have a patient who are actually responders to anti-VEGF. But despite that, I switched them to Ozurdex not for the sake of extra treatment, but to decrease the burden of the anti-VEGF injections when it is on monthly basis or every 2 months. So we should add up the Ozurdex or the steroids in the treatment, whether they are responders or non-responders. Do you agree or not? We can use the Delphi method here.
Yeah, I mean, this combination treatment has not been trialed. There's no clinical trial because we need one company to produce the 2 drugs, and then they will run the trial.
Yeah.
No, the problem is that who's going to pay for the drugs? I mean, if you're a producer for the steroids, you have the anti-VEGF, which is, I would say, much more expensive in terms of, the budget that you need to provide, for multiple injections. Since, it is uncomparable. The only problem that we have is just we are scared about intraocular pressure. We are scared about cataract. That's it, because there's no game. I mean, the man is the steroids. I mean, the VEGFs are excellent. Maybe they are less problematic when you have to deal with a disease like this. But if you have to have the wow effect is only up to the steroids.
But like I said before in my first talk, the risk of hypertension is small with Ozurdex, and only the retina specialists are afraid. Because if you are speaking with glaucoma specialists, they are not afraid of using Ozurdex, because the use of Ozurdex means transient hypertension, easily managed, easily controlled by a topical drop.
I agree totally with you. I am definitely, we are seeing less and less of rise of intraocular pressure with Ozurdex. And we used triamcinolone long back, and we had this spikes of intraocular pressure, and the rate of filtering surgery is very high. But here it is a totally different perspective, where we have this controlled sub or optimum treatment of steroids that is given on daily basis. So I'm not facing this high spikes of IOP at all with Ozurdex, and the rate of filtering surgery is almost 1% or even less. So yeah, I agree with you totally.
I definitely agree with what you said. Triamcinolone cannot be compared to Ozurdex. And last thing, we do not have to forget that there is also a risk of sustained hypertension with anti-VEGF. So we have also to check IOP in our patients treated with anti-VEGF for AMD patients and DME patients, not only DME.
So we are here. Actually, anti-VEGF is an excellent way and excellent treatment, but the burden. So I agree totally with you that in real life practice, and if I was in the Delphi method, I would definitely give the consensus strong about that. Definitely, we are not giving 8 to 9 injections of anti-VEGF to reach to the 9 letter of improvement. But here is the question, because when we were talking about the MEET study, it is by definition, it is an under-treatment. So every 6 months, it is definitely an under-treatment. So we will not reach to the optimum level. But when you presented the Codikian study and in real life study, we have 1.6 injection per year. And despite that, we reached to 9 letter of improvement. Can you explain this a little bit more?
In the analysis I performed, we had a 1.6 injection with 10 months follow-up. So not really 1 year, only 10 months. And remember that for anti-VEGF, it was with a follow-up of 15 months, 5.7 injections, I think. Why? Because we re-inject probably at a better time, first of all. So we do not have to wait 6 months. So the second injection in real life is made earlier than in MEET study. But like you have seen in diabetic patients, the interval between injections increase, not for all patients, but in the mean of patients, it increased with time. And the case report I showed to you, the recurrence was obtained for the second or third case report. The first recurrence was obtained at month 3.5, but the second recurrence was obtained at month 5, and after it was month 8. You see, so that's why I think in real life, with not a higher number of Ozurdex injection in comparison to me, but yes, the timing was completely different, and that's why we have better outcomes.
Okay. So Avi, for the you gave an excellent presentation about the predictors. Predictors for improvement in vision. So can you certify which of these predictors can go with Ozurdex to start with, and which of them we will better start with anti-VEGF? You mentioned the intraretinal foci.
Yeah. So we saw the algorithm which was presented by Professor Laurent, where patients with proliferative retinopathy, patients with high levels of ischemia may do better with anti-VEGF, whereas patients with diffuse macular edema, high amount of exudates, high amount of hyperreflective foci, chronic patients, patients with long-standing cysts, these ones would do better, and including patients with large amount of subretinal fluid. These are the ones who will do better with Ozurdex. So when you see multiple factors present, and in these long-standing patients, you're more tempted to, or you're more prompted to use Ozurdex rather than anti-VEGF.
Yeah, I agree with you. So for Professor Kurikian, for the algorithm, when do you start with Ozurdex, for example, in phakic patients? These patients, when you'll consider, for example, the Ozurdex would be more suitable to start with, and would be first line.
I think it's sometimes not only one criteria. That's why I wanted to show it in this very wide algorithm. There are different boxes, and sometimes you can mix some different boxes. Nevertheless, to answer your question, I think the first line indications for Ozurdex is patients with inflammatory biomarkers on the CT, like serous retinal attachment, hyperreflective foci, hard exudates, etc. Patient with a history of vitrectomy, patient with history of infarction or stroke, patient that are not able to come every month during the first 6 months, because the only way can we have good results with anti-VEGF? Of course we can.
Yes, yeah.
Of course they work. But the only way for anti-VEGF to work is to inject 8 to 9 times the first year. And the only way to have 8 to 9 injections of anti-VEGF the first year is to have 5 to 6 injections the first semester. So to respect the aflibercept label. And the only way to have 5 to 6 injections the first semester is for the patient to come every month. So if your patient is not able to come every month during the first semester, please forget anti-VEGF and use as a first-line therapy Ozurdex. So this is one of the indications. I would add also probably pseudophakic patient. You asked me for phakic patient, I'm sorry.
Yeah.
And probably if you plan the cataract surgery. If you plan the cataract surgery in a phakic patient, it's much better to use Ozurdex because the risk after surgery to have an increase of macular edema. But the increase of macular edema after surgery is not a DME. It's a post-operative macular edema in addition to a diabetic macular edema. And we know that post-operative macular edema corresponds to an inflammation of the posterior segment of the eye. And how to treat or to prevent a posterior inflammation? Is it better to use an anti-inflammatory drugs or to use anti-VEGF drugs? I think you have the answer.
Great. So, what about you, Dr. Neri? So, what is where the Ozurdex comes in your practice as the first line?
Well, actually, I spent roughly 20 years of my career being an ocular immunologist. So I want to bring my experience. And Avi is a colleague of mine, and under this aspect. And I had also the pleasure to work with Laurence when we worked for the UVIS project for adalimumab. And actually, I want to bring my concept here. I was trained for medical retina and uveitis, and mainly as an ocular immunologist. So in immunology, we do exactly the contrary. So we are very tough at the beginning to be very smooth along the time. So let's say that when I have to treat a non-infectious disease, non-infectious inflammatory eye disease, and non-infectious uveitis, I use a lot of steroids at the beginning, and then I try to use the steroid-sparing drugs. This is the concept, since you have to pin down the disease at that time. Medical retina specialists are doing, exactly the contrary. So just keeping injecting, and when they see that there's no other option, they go for the steroids. I would ask a question. Is there any conflict between anti-VEGFs and the steroids? If we start with the steroids and try to minimize the number of injections of anti-VEGF, I see, and I'm very glad that Professor Khoshakian is smiling to this proposal, because I think it's very wise. I think we need to be very tough at the beginning, maybe inject all.
It's fair.
I would avoid, the one that is, very long acting. Ozurdex is perfect. It's in between 3 to 6 months. This is exactly what we want. And then we can use as a supportive treatment the anti-VEGFs. Well, of course, this is not for drug companies, but I believe it's very reasonable. And I leave the other two colleagues to tell their opinion. I really wish to know about it.
To be honest, I'm very happy to hear that from an American guy. Because it's rare, and I think that you have this feeling because you are not only a retina specialist, you are also a uveitis specialist, and that's why you have the use to manage steroids, contrarily to many of your American colleagues. And as for me, I'm also a uveitis specialist like you, and that's why I have the use of steroids. So I definitely agree with you, my friend, completely.
Thank you very much. One is on my side. Let's see, Avi.
No. I mean, look, we are used to injecting Ozurdex and giving steroids in young patients, in children, and phakic. It doesn't matter, right? For the uveitis, you need to use steroids. So we're not afraid, and we've seen that everything can be managed if you control the disease.
So let's say that for this mini Delphi, we got 3 on 3, right?
I would give my opinion as well. So 4.
So perhaps, I guess in an ideal world, a combination treatment might be very, very useful. But we've also seen from, the Iluvian study that the the steroid does improve the diabetic retinopathy score. So there is some amount of the retinopathy does get suppressed, although in Bevadex that was not the case. So I guess we have to keep a watch on the retinopathy when you're using only steroids, because in Bevadex patients had more, the patients on steroid had more retinopathy, but as long as you keep a watch on that, should be okay.
Yeah.
I agree with you all. Yes, definitely for steroids, the other way around. So, for example, if we are using steroids and to start increasing the interval in between the injections, we may use anti-VEGF in between just to prevent this fluctuation of subretinal and intraretinal fluid. Go ahead.
Can I say something?
Yes.
I mean, ophthalmology, let's say medicine, science, and art, it's not a cookbook. So the thing is that, I started my activity, when there was not even triamcinolone at that time. And actually, medical retina was handled by people highly skilled with a lot of wise observations. I remember, the public injections, mean, median. I respect this, but Donald Guss said one thing that was really, really wise, is that if you use statistical analysis to prove if something is working or not, it probably doesn't. So the problem is that, of course, we need to rely this. This is a very strong, statement. But one thing that I believe is important is that how many injections do we have to get? Of course, we need to rely to science, but the disease itself is telling you the story. You get an injection, there's no edema, the patient recovers the visual acuity. Should you keep injecting or should you keep just observing? The disease is telling you what? How many times you have to inject the steroids? Of course, I wouldn't inject the steroid every single month. But of course, if you see that the response is in between 3-6 months is satisfying, and you see that you can even stratify, the sample, telling if you have a worsening of 100 microns, inject an anti-VEGF. If you come back to 300 microns or more, then the normal retinal thickness, go for the steroids. I mean, the logical assessments and statements are so rare at this time. So I really ask everyone listening to us, use your brain. That is my opinion. I don't know whether I can be acknowledged, but I think it's very, very logical.
We'll use your brain, Pier Giorgio.
No, use your brain. It's better. I'm getting older, I had long hairs long time ago, and I had also a very black beard, but you see, I'm getting older.
It's a very smart advice.
Yeah. I think with this very smart advice, we can conclude our session. I would love to thank you all, especially Professor Kolikian, great experience and great presentations. Professor Neri, my dear friend, and Dr. Avi here. So thank you all. And with that, we conclude our session. And definitely, overall, I would like to thank all our attendees who stayed for a long time with us tonight, and to thank the ESO, the American Society of Ophthalmology, for all their support. And thank again Allergan for their sponsoring this session. Thank you.
Thank you very much.
Thanks, everybody. Happy Halloween.
Thanks.
Bye.
Thank you.
Bye-bye.
Bye.
Bye. Take care.